Good morning, everyone. We'll go ahead and get started with Grand Rounds this morning. We still will have our talk on prostate cancer screening with Dr. Adam Abraham. Before that, we're going to do the Divisional Research Awards as well as Clinical Care Awards. And so I will turn the floor over to Dr. Cruz and Dr. Doolin for those. And then after that, I'll come back up and announce Dr. Abraham.
Thank you, Dr. Fust. So I get to have the very pleasant opportunity of announcing two of our excellent researchers. I'm going to go in order of our slide there. So our first awardee is Dr. Matthew DeCamp, a practicing internist, health services researcher, and philosopher. Dr. DeCamp is an internationally recognized researcher studying challenges at the intersection of healthcare policy and bioethics. He's been a sought-after lecturer presenting at medical schools and conferences around the country, ranging from settings and sites as diverse as the University of Iowa to Children's Hospital of Pennsylvania, to the American Thoracic Society, to the World Health Organization, based on his expertise on artificial intelligence in medicine, patient engagement and organizational decision-making, and global health ethics. He's exceptionally productive with over 100 peer-reviewed publications. He's an active mentor. I counted over 24 mentees, ranging from pre-docs to faculty mentees, to highlight his role in advancing ethical standards in research and practice while shaping the next generation of scholars. Dr. DeCamp holds numerous leadership roles that reflect his broad impact across research, ethics, and community engagement. Since 2022, he served as Director of Research Ethics for our Colorado Clinical and Translational Sciences Institute, and he's now also an executive committee member as part of the CCTSI's Partnership of Academicians and Communities for Translation Council. And his service extends nationally with numerous roles on NIH grant review committees, as well as institutionally on groups like the Colorado Community Engagement Alliance Against Health Disparities Advisory Group. With that sort of long and prestigious introduction, I'd like to, I'm so pleased to highlight Dr. DeCamp's excellence in research for this award. And our second awardee is Professor Amy Hubschman, another exceptionally productive clinician investigator. Dr. Hubschman is an independently funded PI with funding from diverse institutes, from NIDDK to NCI to NHLBI at our National Institutes of Health. And she's a nationally recognized leader in implementation science. She has a scholarly portfolio of roughly 100 peer-reviewed publications, and she holds multiple leadership roles across campus, including serving as director of the HRSA-funded Primary Care Research Fellowship, or T32. She's a lead scientist and senior faculty member with the Ludeman's Family Center for Women's Health Research and the National Resource Core Director for the Colorado Center for Diabetes and Translational Research within the Centers for American Indian and Alaska Native Health. In addition, she founded the University of Colorado's Graduate Certificate in Implementation Science to advance training in the field. Her research and leadership have driven impactful contributions to dissemination and implementation science, including high-quality publications in the JAMA Network journals, Implementation Science, and Annals of Internal Medicine. And alongside these accomplishments, we always like to take the chance to recognize Dr. Hubschman for her outstanding mentorship and sustained commitment to developing the next generation of scientists. Her trainees consistently describe her as deeply dedicated, insightful, and an authentic mentor who prioritizes their success. Her mentees have described her mentorship as extraordinary and career-defining, using their language specifically. So I'm so pleased to recognize Dr. Hubschman for her excellence in research.
So I will try to follow that up with the Clinical Excellence Awards. Everybody on this list has really done an exceptional job with clinical metrics, quality measures, overall patient care for years. This year doesn't stand out above and beyond the excellent work that they've done for many, many years. I do want to congratulate all of them for coming up with very interesting photos for this year. To point out, Elena Lebduska, who works at Lowry Internal Medicine, is at her favorite place in the world, Glacier National Park. Steve Fust is with his biggest fans. He works at Anschutz Internal Medicine. Tyra Fainstad, also from Lowry Internal Medicine. This is from Lions. She claims that there's no photoshopping involved in this picture, and photo credit does go to her daughter. Katie Studarth, another doc at Anschutz Internal Medicine, on vacation with her favorite crew. And Whitney Vukatek, both the medical director and clinician at Lowry Internal Medicine, is there in Hawaii, next to her husband, whose beard Steve will hopefully work towards in the future. But really great work for many, many years from all of these folks, and congratulations to them.
I will now take a moment, get our slides swapped over. Sarah, can you see that? No. Thank you. Really appreciate it. Wonderful. All right. This morning, I'm really excited to also introduce Dr. Adam Abraham, who's here to talk to us about prostate cancer screening in the year of 2026. Dr. Abraham did undergraduate at Cornell Medical School, at Temple, and then residency here at the University of Colorado. Dr. Abraham describes himself as someone seeking to understand evidence and uncertainty to guide patient care. Outside of work, he enjoys the usual Colorado activities, reading, and crosswords. And when someone is asked to speak at Grand Rounds, we ask them to submit a headshot for the weekly email that goes out. And I have to say, Dr. Abraham is the first person to send in a photo of themselves with an owl on their shoulder. I don't know the backstory, and I'm really excited to learn about this in the future. And with that, Dr. Abraham, thank you.
All right. Well, thank you, Steve. The backstory about the owl photos is not a part of the lecture today, but can talk about that afterwards if you want. I'm excited to talk to you all about prostate cancer screening in 2026. It's nice to see some faces in the audience that I haven't seen in some time. I want to start with an anecdote about my preparation for this talk. So I gave a version of this talk less than 2 years ago now up in Estes Park at the summer conference that the division puts on each year. And at that time, as I was preparing for the talk, I knew that the U.S. Preventive Task Force was updating their current guidelines, which had last been updated in 2018. But by the time I gave that talk, those guidelines had not been released, and so I couldn't include them in the 2024 talk. Well, fast forward a year, and Steve contacted me around this time last year and said, Adam, would you be willing to, give this talk to the audience that we have for general internal medicine rounds? And I thought to myself, this will be pretty easy. I'll just, recycle my talk from the Estes Park talk, update it with the U.S. Preventive Task Force guidelines, and I'll have, basically a prepared talk. But at that time, the guidelines still hadn't been released. Well, fast forward another year, and this is about a month ago now, and I know I need to put this talk together, and I still haven't seen the U.S. Preventive Task Force guidelines that I expected to come out in late 2024. So I went to my favorite AI, Google Gemini, and I said, what's going on with the U.S. Preventive Task Force and their guidelines on prostate cancer screening? And I learned that, unfortunately, like much that has changed over the past year and a half, the U.S. Preventive Task Force, according to Google Gemini, is in a state of, quote, dormancy. So apparently 5 of the 16 members have not been replaced. They have canceled the last 3 meetings, and there's no word on when they'll reconvene to update those guidelines. So the bottom line is that my plan to be lazy and just kind of update this talk using that as a guide went by the wayside. And so I had to look at other literature and resources. And I found out that since I gave that talk in 2024, There have been updates in systematic analysis and systematic reviews and meta-analysis on randomized controlled trials for prostate cancer screening. There's been an update of the largest randomized controlled trial following men out like 23 years at this point that we'll talk about. And there have been updates to the National Comprehensive Cancer Network guidelines, which are totally different from guidelines I had seen before about prostate cancer screening. Bottom line is I learned a ton over the last few weeks preparing for this lecture, and I'm looking forward to sharing that information with you today. Couple of disclosures before we get into the heart of the talk. When I was young and foolish, I hoped that I could invest in the next Apple or NVIDIA. This is not a good way of arranging your finances, by the way, but I did buy some individual stocks, and one of them I still own is a company that does create equipment for robotic surgical procedures, including robotic prostatectomies. So obviously a potential bias. I'll say it's a very small portion, less than 0.5% of sort of my overall holdings. I don't think it influences my talk, but there you have it. Second is a personal revelation. So I'm 51. So I'm coming at this talk not just as a provider of healthcare, but also a consumer of healthcare and someone who's around the age where they have to decide whether or not to personally be screened for prostate cancer. And then the third thing I'll say is just an apology up front. Most of the literature that talks about prostate cancer screening refers to patients as male. I am going to unfortunately slip back to that pronoun, I think, from time to time during this talk. I realize that not all patients with prostates identify as males, and I'll apologize up front for using that pronoun loosely. All right, let's start with a case presentation. This is a 55-year-old healthy Caucasian male, so someone a few years older than me, presents to your clinic for routine wellness exam. Like all of your patients, I'm sure he has no complaints when he's coming in for his routine wellness exam, but he wants to see his healthcare provider annually to stay healthy. There's no family history of prostate cancer in this gentleman's family. So I'll be quite honest, prostate cancer is on the list of things that I want to talk about with this gentleman. It's not at the top of the list. I'm more concerned about cardiovascular risk or maybe behavioral health for this patient in terms of keeping him healthy. But because this is a lecture on prostate cancer, I wanted to get a sense of where you guys are with a few kind of pre-lecture questions. Caveat is I'm not going to give these answers right away, but I will give the answer to the questions as we go through the presentation.
Okay.
All right, so the first question. In the European randomized study of screening for prostate cancer, the acronym is ERSPIC. These guys need the cardiology marketing folks to give them better acronyms. But how many men like this one needed to be screened over a 9-year period to prevent one death from prostate cancer? Is it A, 570, B, 1,410, C, 2,130, or D, an infinite number because the study was negative and didn't show any mortality benefit over 9 years? So I'll give you about 10 seconds and then we'll move on.
And for the audience response on Zoom, we have about 10% saying choice A, 570, 14% saying choice B, 1,410, 45% saying choice C, 2,130. And then I apologize, these numbers won't add up because it's a dynamic poll, but about 30% saying the study was negative.
All right. So good spread. So obviously some correct answers, some incorrect. We will get back to the answer to this question down the road. Let's see. Steve, I'm having a little trouble forwarding the slides here. Okay.
Now we've clicked again.
Great. All right. The second question deals with that updated guidelines from the NCCN, the National Comprehensive Cancer Network. So with respect to prostate cancer screening, which of the following is true based on their current guidelines? Is it A, screening for prostate cancer should be patient-driven and only occur if the patient mentions the topic? Is it B, initial screening for prostate cancer should include both PSA and digital rectal exam? Is it C, if this patient's PSA is greater than 4, they should be referred to urology for a systematic biopsy? Is it D, if this patient's PSA is between 3 and 4, they should get an MRI? Or is it E, all of the above are true? Once again, we'll give you about 10 seconds and then Steve will announce the answers. Any updates, Steve?
Yes, the answers were a little slower to come in for this one, and they're all over. So for A, screening should only be occur if the patient mentions it, 21%. B, initial screening should have the PSA and the DRE, 5%. C, if the patient's PSA is greater than 4, refer them to urology. Answer was 16% of the audience said that. If the patient's PSA is between 3 to 4, they should get a prostate MRI, 32%. And then all of the above was 26%.
All right, great. Final question. Approximately what percentage of patients with low-risk prostate cancer, and this is defined as Gleason 3+3, I'll use the term low risk, Gleason 3+3, and clinically insignificant prostate cancer. Those are all terms kind of used in the literature for these patients. But this question deals with active surveillance. So what percentage of these patients receive active surveillance now as compared to just 15 years ago in 2010, approximately? So is it A, approximately 60% now versus 15% in 2010? Is it B, 10% now versus 5% back then? Is it C, 90% now versus 15% in 2010? Or is it D, 95% now versus 55% 15 years ago?
And the answers are flying in for this one. So choice A got 45%, choice B, 27%, choice C, 0%, and choice D, 25%.
All right. So remember your answers. We'll come back to those questions as the talk goes on. That'll kind of frame our discussion as we go along. All right, so just a few learning objectives for this talk. First, I'd like you to be able to discuss the elements of a good screening test, specifically in relationship to prostate cancer screening. Second, I'd like you to become familiar with the current NCCN guidelines, not just the guidelines, but also the evidence supporting them. And we'll spend a lot of time talking about that evidence. And then finally, I like the talks that I attend and the talks that I give to have some clinical relevance. So my hope is that you're able to use the knowledge that you get from this presentation and bring it back into the clinic so that you can better inform your discussions with patients about prostate cancer screening. Just a quick step back to take a look at the background and history of PSA screening. So the PSA test was first approved in 1986, not as a prostate cancer screening test, but as a test to monitor patients who had been diagnosed with prostate cancer. And then about 8 years later, it was FDA approved as a screening test. And I'll note that there was no evidence of improved patient outcomes when it was rolled out as a screening test for patients. So this graph shows the incidence of prostate cancer between about 1980 and 2020. And you can see that starting in the mid-80s, when the PSA is released as a test to monitor prostate cancer, the diagnosis or incidence of prostate cancer rises dramatically. Now, this graph obviously doesn't prove causation, but I think most experts that have studied this do feel like the introduction of PSA testing dramatically increased the number of diagnoses of prostate cancer screening directly because of the availability of PSA test. Plateaued for a while at a pretty high level. And then in 2008, I don't know if anybody remembers what happened then, but the U.S. Preventive Task Force actually came up with guidelines that recommended against prostate cancer screening for men over the age of 75. So with that, the PSA started to be used less frequently, and the incidence of prostate cancer dropped correspondingly. In 2012, the U.S. Preventive Task Force actually recommended against prostate cancer screening for all men. And interestingly here, the rates initially declined and then start to rise. And this rise actually corresponds with later stage prostate cancers. So there was a rise not just in early stage prostate cancers, but it seemed like men were getting diagnosed a little bit later And the theory is that perhaps men weren't getting screened as much and were starting to present with clinically significant prostate cancers. And then in 2018, that's when the USPTF most recently updated their guidelines. And most of you probably recall that they recommend shared decision-making for men between 55 and 69. And they recommend against prostate cancer screening for patients over the age of 70 with a prostate. I like this quote from Archie Cochrane, who is considered one of the founders of evidence-based medicine, just talking about principles of screening tests. And I'm just going to read it. He says, if a patient asks a medical practitioner for help, the doctor does the best he can. If, however, the practitioner initiates screening procedures, they're in a very different situation. They should have conclusive evidence that screening can alter the natural history of disease in a significant proportion of those screened. So what Cochrane is saying here is basically that if we're going to go searching for a disease that isn't presenting with any signs or symptoms, we should have pretty good evidence that what we're searching for, we can make an outcome, we can create an outcome where the cure is better than the not knowing about the disease itself. And that's kind of the rub with prostate cancer screening that we'll talk about. In general, these are ideal features of a screening test for a population-based screen. And we'll talk about how it relates to prostate cancer. So the first is that the disease in question should be common and associated with significant morbidity or mortality. So in general, you don't want to screen for diseases that aren't very common in the population. And I think prostate cancer does meet this criteria. About 11 or 12% of men will be diagnosed with prostate cancer during their lifetime, and about 3% of patients with a prostate will succumb to prostate cancer. Second is that the test should be easy and safe to administer. And I do think that PSA testing meets that criteria as well. It's obviously a blood draw, which is very easy to administer, can be done in most healthcare settings, and obviously blood draws are very safe. Third is that the test is reasonable in cost. I've seen estimates of anywhere between $50 to $300 for PSA screening, but compared to a lot of things that we do in medicine, obviously that cost is fairly insubstantial. Tests should be reproducible. I think PSA also largely meets this standard. There are some things that can throw off your PSA level. So trauma to the prostate, an infection, even a digital rectal exam can sometimes cause the PSA to vary a bit. But in general, a PSA is a fairly reproducible test. All right, you may remember from epidemiology class in med school, a screening test should have a high specificity. And you might recall that specificity is the probability that a test will be negative, assuming a patient doesn't have the disease. And you can alter the specificity depending on which cutoff you choose for your PSA level. But in general, with the levels that we use of 3 to 4, I've seen specificities quoted somewhere in the 80 to 90% region. Ideally, you want your specificity and sensitivity to be as close to 100% as possible. But 80 to 90% isn't bad. So prostate cancer screening, I think, meets this standard as well. Sensitivity, on the other hand, is the probability that a test will be positive if the patient has the disease. And it's interesting for prostate cancer. The best study that we have that looks at this is from 2005. And this study looked at a number of men, and at the end of the study, regardless of what their PSA was, all of these men received a prostate biopsy. I don't know how they recruited or what the incentives were for men to enroll in that study, but that's what they did. And so they found that if we're looking at histologic prostate cancer, so that is, cancer diagnosed from biopsy, sensitivity was actually really bad. So if we use 4 as the cutoff, which is what we typically have used in the US, they found a sensitivity of about 20%, meaning that the probability that a patient had a PSA of greater than 4 if they had prostate cancer on their biopsy was only 2 out of 10. If they reduce that level to 3, the sensitivity increased somewhat to about 30%, but still pretty poor sensitivity for that test. So that's histologic prostate cancer. And one of the things that we'll talk about is that most of these prostate cancers that they diagnosed with biopsy were very low-risk prostate cancer. So whether or not you want to know about those is a question to begin with. If you're looking at higher grade prostate cancers, the sensitivity is better. It's somewhere around 50 to 60%, but still not great. And then finally, and I think this is really the most important feature that makes prostate cancer screening controversial, is that the disease should have a treatment or cure that's widely available that leads to better health outcomes than if the disease was left undiagnosed or untreated. And that, I think, has been the question throughout the years that I've been practicing about prostate cancer is the treatment actually better than, than not knowing in many of these men who have low-risk prostate cancer? Well, there are certainly some proponents of prostate cancer screening, some famous folks out there who have been diagnosed with prostate cancer and widely advocate for prostate cancer screening. So Ben Stiller has been quoted as saying, taking the PSA test saved my life, literally. Alonzo Mourning, famous basketball center for the Miami Heat, also has spoken out about the benefits of getting screened for prostate cancer with a diagnosis several years ago. So those are sort of celebrity endorsements of prostate cancer screening, but what does the evidence say? And there have been some RCTs looking at prostate cancer screening. The one I'm going to focus on the most is that European trial that's in red, and we'll talk more about that on the next slide. But I remember practicing in 2009 when both the European study came out and the PLCO, which was a large trial that was done in the US, came out around the same time. And the PLCO looked at tens of thousands of men in the US and was a negative trial. They found no difference in prostate cancer outcomes over the decade that they followed men. Problem with this study is that because it was done in the US at the time that PSA was widely available, the control group was highly contaminated with folks who had received prostate cancer screening during the course of the study. And I've seen estimates of 80 to 90% of folks who were in the control group had a PSA at some point during that trial. So it was really a trial looking at sort of systematic prostate cancer programs versus opportunistic screening, as opposed to sort of screening versus no screening. The European trial was much less contaminated, and I'll go into more detail on that in a moment. These other trials are much smaller studies. The 2004 Canadian study and the 2018 Swedish study. When the USPTF looked at those studies, they found methodological flaws and didn't include them in their 2018 review. And the 2018 study that's listed here, the cluster randomized trial, that was a British study that looked at just screening at one point in time rather than serial screening, which is what we do here in the US. So I think this trial, which was done throughout Europe, probably most closely approximates what we do here, or what we traditionally have done here, although with some key differences that we'll talk about. So this was a trial done throughout Europe in 9 different countries. It looked at over 160,000 men between the ages of 55 and 69. But they employed different methods in different countries. And in general, they were very different from what we do here. So most of the countries used a PSA cutoff of 3, whereas we have traditionally used 4. Although in Sweden, they use a cutoff of 2.5. And most of the countries screened every 2 to 4 years as opposed to annually, which is kind of historically what we've done in the US. Most sites actually screened every 4 years, although in Sweden, they screened every 2 years. So some key differences compared to what we do here. But they actually did have a positive outcome. So they first published trial data after following men for about a decade, 9 years. And they noticed that there was a relative risk reduction in prostate cancer mortality of about 20% in the screened group versus the control group. But when they looked at the absolute risk reduction, it was quite small. So 0.071%, which equates, if you divide 100 by that number, you get a number needed to invite of over 1,400 men to prevent one prostate cancer death over about a decade. So that is the answer to the first question. In this study, you needed to screen about 1,400 men, or invite, I should say, 1,400 patients to screening to prevent one prostate cancer death over that period of time. They've continued to follow these patients, and they released updates in 2013 and 2016. And then in October of last year, they released their final update. And this followed men over 23 years. And you can see that the absolute mortality reduction actually improved to some extent. So it was 0.22%, which equates to a number needed to invite of 456 over 23 years. So looking better as we follow men out more than 2 decades. This is hot off the presses, just released a few weeks ago online from a European urologic journal. This is a meta-analysis that has kind of looked at all the randomized controlled trials with respect to prostate cancer screening. And I'm just going to highlight 2 slides that focus on mortality, prostate cancer-specific mortality. The first one looks at men that were screened for about 10 years in different trials. And I don't know if my pointer shows up here, but the green diamond at the bottom there is sort of the conclusion combining all these reviews. And you can see that it slightly favors screening, although I will say the tip of that diamond just hits the 1 on the confidence interval. So marginally statistically significant in terms of reduction of prostate cancer mortality over 10 years. But they also looked at trials that followed men longer, and these trials ranged anywhere from 15 to 23 years. And the signal becomes a bit stronger as you look out several decades. So they did find a statistically significant benefit in men who were screened for prostate cancer in terms of mortality reduction over about a 20-year period. Well, how does this compare to other cancers that we commonly screen for? So I created this slide just to show sort of a ballpark estimate of other common cancers we screen for in terms of number needed to invite or number needed to screen to prevent 1 death from cancer. And you can see that prostate cancer at a decade compares fairly favorably, at least to the outcome of a trial that was published on breast cancer screening with mammography. So over a decade, both of these had a point estimate of about 1,400 to prevent one death. As we get to 23 years, prostate cancer sort of approaches colon cancer screening over a decade and lung cancer screening, which is actually the best screening test, over 6.5 years. Just as an aside, I find it interesting that we have to document shared decision-making for smokers when the point estimate for lung cancer screening is much better than it is for any of the other cancers that we screen for. But we don't have to have shared decision-making conversations with men or folks with a prostate to screen them for prostate cancer. All right, so what's the downside? Why is this controversial? I've showed some data that indicates that we probably are improving health outcomes in terms of prostate cancer-specific mortality. Why is this a controversial topic when we talk with patients about screening? We don't really think about this with breast cancer screening or lung cancer screening or colon cancer screening so much. Well, I think the main reason is the risk of overdiagnosis. And what I've historically told men in my practice is that prostate cancer tends to be a very slow-growing cancer. Not always, but most prostate cancers tend to grow very slowly. And there's a good chance that if you're diagnosed with prostate cancer, you will succumb to something else. And the treatment for prostate cancer, as we'll see, has significant morbidity associated with it. So overdiagnosis basically is the finding of a disease that never would have become clinically apparent unless we looked for it, and never would have caused any morbidity or mortality during a patient's lifetime. How often does that occur with prostate cancer? Well, estimates are, at least traditionally, it's pretty high. So about 25 to 50% of prostate cancers are estimated to be overdiagnosed and would never have clinical symptoms unless we looked for them. This is data from that initial ER-SPC trial that came out in 2009. The caveat is that the Gleason score has been modified, so this reflects sort of the old scoring system. And you can see that in the screening arm column, about twice as many men are discovered to have sort of early stage prostate cancer as compared to the control arm. And about 3/4 of the prostate cancer diagnoses in the screening arm were what were historically classified as low-grade prostate cancers. With our updated Gleason scoring scale, what's the natural history of low-risk prostate cancer? So Gleason 3+3 or 6 prostate cancer, what happens to these patients? Well, this is data that comes from a 2025 cohort study of men who they followed for 15 years with active surveillance. And you can see that about half the men did not have any upstaging of their prostate cancer and required no treatment whatsoever. About 3% of men developed metastases during that time, but only 8 men in this entire sample passed away from prostate cancer. So low risk prostate cancer, at least with our current Gleason score, is a pretty indolent disease. It certainly can spread over time, but at 15 years, only about half of men required treatment. This was a chart that I found pretty informative, looking at estimates of what would happen to men if we did serial prostate cancer screening for 13 years based on the clinical data that we had. So if you take 1,000 men and you screen them with PSAs and they're between the age of 55 and 69, and you look at them for 13 years, about a quarter of them will have a abnormal PSA that will lead to a biopsy. About 100 of those 1,000 men, so about 10%, will be diagnosed with prostate cancer over those 13 years. About 3 of them will be prevented from having metastatic prostate cancer, according to the trial data. And about 1 man's life will be saved over those 13 years, according to the estimates that we have. The bad thing is that about 50 men at the end of this trial will wind up with sexual dysfunction, at least with historical treatments, and about 15 will have urinary incontinence. So one could argue that if you screen for prostate cancer, you're 65 times more likely to wind up with erectile dysfunction or urinary incontinence than you are to have your life saved from the screening. So this is the dilemma. Our goal is to find clinically significant prostate cancer at an early stage and intervene where we can reduce morbidity and mortality. But the problem is that historically, we're probably overdiagnosing a lot of prostate cancers and potentially causing a lot of morbidity from the treatment. So have we made progress? And this is where I really learned a lot over the past few weeks, kind of preparing for this lecture. And the answer is yes. I think we've made significant progress in a few big areas. So the first is this concept of MRI prior to biopsy. And we'll talk a lot about that over the next few slides. The second is incorporating active surveillance rather than active treatment in patients with low risk prostate cancer. And then the third, which I only have one slide on because I don't think it's quite ready for prime time, but is an active area of investigation. And that's incorporating other risk stratification tools other than the PSA. So sort of blood tests or other risk factors that we can plug into a calculator to determine whether or not a patient needs a biopsy that are more advanced than just a PSA alone. So let's talk a little bit about MRI trials that have looked at sort of MRI as an intermediate step. So in the old traditional regime, we would take men who had elevated PSAs and just refer them for biopsy. This is looking at whether or not doing an MRI prior to biopsy could be helpful in terms of reducing biopsies and overdiagnosis. So this study was a Swedish population-based screening study, had about 1,500 men that were enrolled. In this study, if patients had a PSA that was greater than 3, they were randomized into one of 2 groups. The experimental group got an MRI, and if the MRI didn't suggest prostate cancer, they actually would not get a biopsy. But if the MRI suggested prostate cancer, then they would proceed to biopsy. And then the standard group just sort of got our traditional biopsy if their PSA was elevated. It was set up as a non-inferiority trial. So their primary outcome was whether or not they were identifying clinically significant prostate cancers at the same rate in both groups. But their secondary outcome was whether or not they could reduce the diagnosis of non-clinically significant, those Gleason 3+3 prostate cancers. And here are the results. Their primary outcome was met. In fact, patients in the experimental group had a slightly higher percentage diagnosis of clinically significant cancers, but clinically insignificant cancer rates were only about a third in the MRI group as compared to the standard biopsy group. Your chance of getting a biopsy was about 1/4 if you had an MRI first as compared to just proceeding to biopsy right away. I'm sorry, your chance of having a benign biopsy. So your chance that your biopsy would be benign was about 1/4 if you had an MRI first as compared to just going straight to biopsy. And then I thought this graph was interesting. This just sort of extends this trial data to 10,000 men and shows the differences between the blue group, which is a standard biopsy group, and the red group, which is the MRI prior to biopsy group. You can see in the standard biopsy group, you have many more biopsy procedures, many more benign biopsies, the diagnosis of many more Gleason 6 or clinically insignificant prostate cancers. And then the things that we care about, so the intermediate or high-grade prostate cancers, seem to be equivalent in both groups. So this is one small study, just 1,500 men. But over the last decade, there have been a plethora of studies that look at this question. And just last year, or 2 years ago, I should say, a systematic review and meta-analysis was published that looked at the trial that I presented, along with 11 other studies, looking at over 80,000 men, multiple different countries, and the conclusions were basically the same. So compared to PSA screening alone, the sequential pathway was associated with many fewer biopsies, fewer diagnoses of Gleason 3+3 cancers, and equal diagnoses of clinically significant cancers. So the conclusion, I think, based on multiple studies looking at tens of thousands of patients, is that integrating MRI into our prostate cancer screening regimen is associated with reduced number of biopsies, reduced overdiagnosis of insignificant prostate cancer, but it seems to maintain detection of clinically significant cancer as compared to the old method of just going straight to biopsy. So the NCCN, which updated their guidelines last year and then kind of updated the version this year, has incorporated MRI into their current guidelines. So we're going to go through sort of their major recommendations, including MRI. So NCCN now says that patients who opt in for PSA testing that have a prostate should get PSA testing between the ages of 45 and 75. Interestingly, the most recent updated version from this year, it removes the explicit instruction to, quote, discuss the benefits and harms in the risk assessment portion of the algorithm. So you could argue that they're removing it because they still recommend counseling, and so it's sort of redundant. Or you could argue that they're moving more towards recommending universal screening as compared to shared decision-making. They still do recommend counseling, and they do not explicitly recommend universal screening. Digital rectal exam is optional initially, according to the current guidelines from the NCCN. But if the PSA is greater than 3, then they recommend repeating it and performing a digital rectal exam. And if the PSA remains above 3, their guidelines incorporate MRI as the next step. And they recommend a biopsy if either the MRI is suggestive of prostate cancer or if the digital rectal exam reveals a nodule and is suspicious for prostate cancer. Interestingly, they recommend rescreening based on PSA level. So if patients with a prostate have a PSA level that's less than 1, they recommend waiting 2 to 4 years to repeat screening. If the level's between 1 and 3, they recommend rescreening in 1 to 2 years. And if the level is higher than 3, but the patient doesn't have prostate cancer on further workup, they recommend repeating PSA testing somewhere between 6 to 12 months down the road. So going back to that second question that I asked, the correct answer to this one is that if the patient's PSA is between 3 and 4, patient should have an MRI of the prostate prior to biopsy, according to NCCN current guidelines. Okay, this is the slide on kind of risk scores or risk calculators that are currently in development. I just have one slide on this just to let you know that these are sort of an area of active research and may be coming down the road, although I don't think they're quite ready for prime time. So this study is called the uses the Stockholm 3 score, which looks at 5 biomarkers rather than just PSA. And the goal here is to determine whether or not a patient needs an MRI using something other than just a PSA. Obviously, MRI is a pretty expensive test. It's not necessarily widely available. So if we had something better than PSA to risk stratify patients, we might be able to avoid not just biopsies, but also unnecessary expensive MRIs. And this study actually was a positive study. So it looked at 5 biomarkers, also incorporated age and previous biopsy status into a calculator. If the score was low, the patient did not get an MRI. If the score was high, they would proceed to MRI and then biopsy if necessary. And they found that they were able to reduce MRI use by 36% and maintain the detection of clinically significant cancers from a percentage standpoint. A few caveats here. This test is widely used in Sweden, Stockholm 3 score. You can tell where it was created. It's used in other Scandinavian countries as well, but it's not FDA approved yet. It costs 6 to 7 times more than the PSA test alone, but the goal is to save some costs on the back end by reducing MRIs and biopsies. And there have been cost-effective analyses showing that it is probably cost-effective. It is one of multiple risk scores that's currently under study. And the NCCN, I think, has 5 or 6 of them listed as grade 2B recommendations. So something to consider, but they don't recommend replacing MRI with these scores, at least if MRI is available. Okay, we do have another Al photo here. I didn't have much to add to this question, so I just have a wise old Al here. So can we reduce treatment morbidity? So hopefully I've shown you some slides showing that MRI can reduce the risk of biopsy and reduce the risk of overdiagnosis. The second area is reducing morbidity from treatment in patients with low-risk prostate cancer, and that brings us to active surveillance. So active surveillance involves actively monitoring the disease with the expectation of intervening with curative intent if progression is detected. That's in contrast to active treatment, which would involve either radical prostatectomy or some form of radiation, and which can be associated with significant morbidity. So with prostate cancer screening, this involves repeat PSA testing, potentially repeat digital rectal exams and repeat MRIs, and biopsies if necessary. This sort of came into widespread use after this trial, the PROTECT trial, came out in the mid-2010s. And the PROTECT trial really looked at men with localized prostate cancer. There were 1,500 men in this study. They were divided into 3 groups, approximately equally. So about a third of the patients received active monitoring, about a third of the patients went into radiotherapy, and about a third received prostatectomy. And the bottom line was that over 15 years, the mortality rates in all 3 groups were basically equivalent. So about 3% of men succumbed to prostate cancer over 15 years in all 3 groups. This is just a chart highlighting which men got treatment during the 15 years that this study was underway. And you can see that folks who were randomized to radiotherapy or prostatectomy, not surprisingly, almost all of those patients received active treatment. Those in the active monitoring group, after about 15 years, just over half actually required any treatment whatsoever. So about 40% of the patients who were in active monitoring didn't require any treatment other than surveillance over that time. These are, I think, some important secondary outcomes to think about in this trial. So all-cause mortality, I'll point out, the chance of succumbing to something else was about 6 to 7 times greater in all 3 groups compared to prostate cancer for men in this age group. The one difference is that the active monitoring group did have significantly higher rates of metastases at 15 years, so about double the rate of men in the active treatment group. I will say that at this time, they were not using MRIs for surveillance. So a lot of experts think that these rates would probably be lower under current surveillance strategies. And this is just a graph highlighting prostate cancer specific survival and metastasis-free survival on the bottom. The top line, you can really barely distinguish that there are even 3 lines there. So the mortality seems to be very equivalent over 15 years in all 3 groups. The bottom, metastasis-free survival, you can see that the curves do start to separate at about 5 years, and there are higher rates of metastases in the active monitoring group. So you may ask, well, if there are higher rates of metastases, why wouldn't you treat all of these men? And the reason really is because of the side effects of treatment. So these are some busy charts and a little bit difficult. I hesitated whether or not to put these into the talk at all. But what I want to point out here is that the red line are men who receive prostatectomy, and the yellow and blue lines are men who receive radiotherapy and active monitoring, respectively. Basically, the bottom line is that the chance of incontinence for men who receive prostatectomy is significantly greater. I think the number needed to harm is about 8 for men who receive prostatectomy and about 130 for men who receive radiotherapy compared to active monitoring. And similar slide for sexual function, although the numbers are actually worse. So men who receive prostatectomy, the number needed to harm is about 4 for decrease in sexual function. The men who receive radiotherapy, the number needed to harm is about 8 compared to active monitoring. There's a similar chart that I didn't show for radiation therapy, essentially prostatectomy, looking at bowel function. And if you get radiotherapy, you're much more likely to have bowel issues like bloody bowel movements compared to active monitoring or prostatectomy. So the most recent guidelines from the NCCN and the American Urologic Association have incorporated active surveillance as their primary strategy or preferred management strategy for most patients with low-risk prostate cancer. And those guidelines have been in place for about a decade now. And the uptake of active surveillance has also risen substantially over the past 10 to 15 years. This is another busy slide. I want you just to focus on the box on the left. These are patients who have what's historically been defined as low-risk prostate cancer. The y-axis on this chart is the percentage of patients who receive different treatments. And the x-axis is years from 1990 to 2013. And then the only line I want you to focus on is the one with the blue circles here, which are the active surveillance folks. And you can see the percentage of folks who received active surveillance was really quite low throughout the 1990s and the early 2000s, somewhere between sort of 10 to 15%. But starting around the 2010 timeframe, the number of patients who got active surveillance rises substantially, as highlighted by the arrow here. And so about 30 to 40% of men are getting active surveillance if they have low-risk prostate cancer by about 2010 to 2013. This is a similar chart, just sort of showing from 2014 to 2021. And the light blue here are the bars representing the proportion of men who receive active surveillance if they have low-risk prostate cancer. And it rises from about 30% in 2014, really substantially and really quickly, to about 60% in 2021. So that third question, the answer is that currently about 60% of patients with a prostate that have low-risk prostate cancer receive active surveillance as their preferred treatment currently, compared to just 15% 15 or 16 years ago. All right, I'll wrap up with current society guidelines and then a couple of conclusions. So these are the current society guidelines. Couple of major organizations. The NCCN is the second row there. We've talked a bunch about that. The ACP, our organization for internists, hasn't updated their guidelines since 2013. So it really doesn't include any of the information on active surveillance or on MRIs as a screening modality for prostate cancer. And they sort of still have a don't ask, don't tell policy. So they recommend screening only if the patient prioritizes it and their life expectancy is greater than 10 to 15 years. I think the bottom line is that these are sort of substantially out-of-date guidelines, and I hope that they review this in the near future. And then the USPTF, as we talked about, hasn't updated its guidelines since 2018. It currently recommends shared decision-making for patients between 55 and 69 with a prostate, and recommends against prostate cancer screening for older patients with a prostate above the age of 70. All right, so a few conclusions, and then hopefully we have a few minutes for questions. PSA by itself is a widely available, but I think highly flawed prostate cancer screening test just by itself. Overdiagnosis remains a problem with respect to prostate cancer screening, but I think there's now ample evidence that at least if we look out 20 years, prostate cancer screening does reduce prostate cancer specific mortality. And here's some calculated numbers needed to invite to prevent one death from prostate cancer. So these are numbers to kind of keep in the back of your mind as you're counseling patients. So at 9 years, that number is about 1,400 men. And then at 23 years, the number decreases to 1 in less than 500. So I think differently about a man who's 50 or 55 years old than I would a man who's, 70 years old based on these numbers. The use of MRI and risk score calculators has reduced the rate of biopsies and the detection of clinically insignificant prostate cancers, but it's still preserving detection of higher risk prostate cancers. The NCCN, which are the most currently updated guidelines, now recommend incorporating prostate MRI into screening for patients with a PSA of greater than 3. And insurance companies now will approve MRI for men or patients who have PSA levels above this. And then finally, active surveillance has become the major treatment modality over the last decade for patients with low-risk prostate cancer. And that has the potential to substantially reduce treatment morbidity in these patients. So I started with a subtitle, should we update patient guidance in 2026? And I think I certainly have updated the guidance that I'm giving my patients over the last few weeks in response to, I think, new information that has kind of come out over the last decade and has been consolidated in recent systematic reviews and meta-analysis. And with that, I'll open it up to questions. This is Fletch getting his prostate examined in the mid-'80s. And you can see from the x-ray in the back, they did not have any sort of medical consultants helping them out. All right. Questions on Zoom or in the audience?
We do have some questions for you. So we'll start out with a scenario where there's a negative MRI. If there is someone has an elevated PSA, but they have a negative MRI, does that negate the need for biopsy on its own? Or should we also be considering other factors such as the rate of rise of the PSA and the absolute PSA levels?
Yeah, I didn't do a deep dive into that. I did do sort of a surface review of what to do with patients who have sort of a negative MRI. The NCCN, if the PSA is above 10, they quote that based on studies, the patient has about a 66% chance of having a prostate cancer. So while they don't explicitly recommend biopsying all patients with a PSA of greater than 10, they don't recommend using the MRI as the only tool to determine whether or not a patient needs a biopsy. So that's where some of those risk calculators may come in handy as well. So using other strategies like the rate of rise, PSA density, potentially other biomarkers that you can look at. I think that's still an unsettled area in terms of what to do with patients. But, I think that's where some of those 2B recommendations come into play with the other risk calculators and risk scores.
From this talk, I learned about that NCCN recommendation, PSA greater than 3, go to prostate MRI. And I struggle with that. And the reason I struggle with that a little bit is that I imagine for those individuals whose PSA is between 3 to 4, your pretest probability of an elevated Gleason score is low. And so the lower your cutoff is for the PSA, the more of those low-grade prostate cancers are going to be in there. And so I guess this is a roundabout way of me saying, I don't know what the best PSA cutoff is there for going to prostate MRI, because we're just going to have a lot of negatives probably, or you're going to enrich the number of negatives that you get there, the lower your PSA is.
Yeah, I think it's an interesting point. And I take the point. What I can say is that at least in Europe, in the studies that they've done, they have actually been using a PSA cutoff of 3 for years. The sensitivities, as I pointed out, is actually pretty poor for at least histologic diagnosis of prostate cancer. So if you biopsy everybody, you're likely to find a lot of clinically insignificant prostate cancers. But if you're incorporating MRI, all the data shows that you're actually reducing the number of prostate biopsies that you do. Now, it is true that men between a PSA of 3 and 4, we historically haven't done anything for in the US. But these trials that have come out were really looking at patients typically with a cutoff of 3 in terms of mortality benefit in that European trial that was done. So it is kind of a paradigm shift compared to what we've done historically over the years. But the guidelines are based on the RCT that was done throughout Europe, where 3 was the cutoff in most patients.
The last question for this morning, can you remind us those trials? You don't have to go through every single one, but for the majority of them, were they mostly looking at prostate cancer specific mortality, or were there some that were looking at all cause mortality?
Yeah, so all of them were designed to look at prostate cancer specific mortality. And no study, when they've looked at overall mortality, has found any benefit to prostate cancer screening. But that is the case for most things where we're looking at mortality, because you need just huge numbers to show that there's going to be any reduction in absolute mortality, especially for something like prostate cancer, which tends to be a fairly indolent disease that doesn't cause problems for many decades in most patients.
Thank you very much, Dr. Abraham, for giving us this update on prostate cancer.
Yeah, thank you guys.